very good morning from Agra, where we are currently at the 77th NATCON, or National Conference on Tuberculosis and Chest Diseases. And I'm really honored to have with me today Dr. Animesh Sinha from MSF. He is the TB advisor for TB at MSF UK. MSF, that is Medicine Sans Frontier, or what we commonly know it as Doctors Without Borders, which is a very, very important concept as far as health is concerned. So welcome, Dr. Sinha. And I believe you have been involved with shorter tuberculosis regimens basically for multi-drug-resistant TB, which is actually one of the big pains and is thwarting our attempts to end TB. Our goal is very ambitious in India to end TB by 2025 and according to the SDGs, by 2030. So, can you explain or to our listeners something about the studies which you have been involved in? What have been their outcomes? And then we'll come to access issues later on.
Thank you, Shiva, for the introduction. So, MSF has been involved in a clinical trial called the TB Practical Clinical Trial. The TB Practical Clinical Trial was a trial to find a shorter, safer, and more effective treatment regimen for patients suffering from MDR tuberculosis.
Can I interrupt here for a moment? TB Practical, what is it, an acronym?
It is an acronym. It stands for Pragmatic Clinical Trial for more effective, less toxic treatment regimens.
Oh.
Now, the practical clinical trial trialed three different arms. There was an arm with investigational arms, one arm with bedaquiline, pretomanid, linezolid, and moxifloxacin. The other arm contained bedaquiline, pretomanid, linezolid, and clofazimine, and the third investigational arm contained bedaquiline, pretomanid, and linezolid. And these arms were compared with the standard of care, which was as per the WHO guidelines in these countries. It was a multi-country trial, meaning that we conducted the trial in Uzbekistan, Belarus, and South Africa, and we recruited over 500 patients across these three sites. It was a phase 2 and phase 3 trial, and the best performing regimen from phase 2 was carried forward to phase 3, which was bedaquiline, pretomanid, linezolid, and moxifloxacin. What we found in the trial was that the bedaquiline, pretomanid, linezolid, and moxifloxacin was safer and more effective than the standard of care. And we shared these results with the WHO as well as at the Union Conference last year and the year before last. And this helped in forming the WHO guideline, which was issued in December last year, which recommended that these short regimens be used for patients with MDR tuberculosis.
Okay, can you elaborate a little more when you say it was found to be more effective than the standard of care? So, how effective is the standard of care and how effective is this new treatment?
So, this regimen was found to be effective in 89% of patients, meaning that 89% of patients did not have any unfavorable outcome who were on this regimen, as compared to around 60% of patients who were on the standard of care arm. So that's how effective it was compared to the standard of care arm. Also, the side effect profile was better, meaning that patients who were on this regimen experienced fewer side effects as compared to the patients who were on the standard of care arm. The other important thing I would like to mention is that as part of the clinical trial, we had two sub-studies. One was patient-centered, meaning looking at how do patients themselves feel about their own lives while they are on TB treatment. And we found that patients who were on the 6-month treatment experienced better quality of life as compared to patients who were on the standard of care regimen. So it improves the quality of life of patients who take these TB treatments because mostly because it's much shorter. It's just a 6-month treatment as compared to the 2-year, almost a 2-year treatment that patients get on the standard of care regimen. The other thing we also did was see how economical it is. Whether patients, is it economical enough for patients and is it economical for the healthcare providers? And we found that this shorter regimen, this 6-month regimen with bedaquiline, pretomanid, linezolid, and moxifloxacin was economical both for the patients and for the providers, mainly because of the short duration, meaning that patients had to have in-hospital stay, which was very short, and the follow-up period and the investigations, all of that was drastically reduced. And patients could get back to their lives. They could get back to either studying if they were studying, get back to their working and earning much quicker than if they were on a standard of care regimen. So it's economical, it's better for the patients, it's safer, it's less toxic. There is no reason that it should not be made available to everybody who is suffering from drug-resistant tuberculosis the earliest.
And it's an all oral regimen, I believe.
Yes. So this regimen comprises of 4 drugs, which are all oral drugs. Patients do not have to take long durations of painful intramuscular injections, which they had to in the previous standard of care regimens, where patients would just go deaf. We've seen so many patients who have lost their hearing, who have lost kidney function because of these painful injections. Here, patients don't have to take injection, which again means that they don't have to come to the hospital every day for the nurse to give them an injection, thereby improving their quality of life drastically. All oral drugs.
What about side effect of linezolid? Because that is a sort of a problematic drug as far as side effects are concerned, I believe. How have you
Yeah.
managed that?
So the TB practical clinical trial used 600 milligrams of linezolid in the initial 4 months, which was tapered down to 300 milligrams in the last 2 months of treatment, or earlier if it was not well tolerated. We found that in our trial, linezolid was better tolerated than in the investigational arms, which means in these 6 month regimens, as compared to the standard of care arm. As you know, linezolid is a group A drug, meaning that even if a patient gets a standard of care regimen, it will probably have linezolid.
Oh.
And linezolid combined in linezolid used in a standard of care regimen in our trial was found to have more side effect profile than the linezolid used in a shorter 6 month treatment regimen. So even though linezolid is toxic in higher doses, even though linezolid is toxic when taken for a long time, when taken in the correct dose and for a limited period of time, it is safe and effective.
Okay, amongst those 500 participants for the study, were there some HIV positive people also in the
Yeah.
study?
So the reason we conducted the clinical trial in Belarus, Uzbekistan, and South Africa was because of the varied type of TB epidemic in these countries. Countries in Central Asia and Eastern Europe have got a high proportion of patients who have drug-resistant tuberculosis, meaning that in Belarus, for example, if you get TB for the first time, there's almost a 1 in 3 chance that you will get drug-resistant tuberculosis. If you've been treated in the past and you get TB again, there's a 2 in 3 chance that you will have drug-resistant tuberculosis. So these are areas with high proportion of drug-resistant tuberculosis. South Africa we chose because we wanted to ensure that patients who have HIV do not fall behind in terms of getting better treatment. So we wanted to see whether these patients can also get the same benefit from these shorter regimens. Because South Africa, you have quite a high proportion of patients who have HIV. HIV was not an excluding criteria for our trial, meaning that we did enroll patients who were HIV positive, and regardless of the HIV status, patients did respond well to this treatment.
So now WHO has endorsed this treatment under operational research, or what? What are the
So the new WHO guideline update, which was issued in December last year, just a couple of
right,
months ago, recommended that this regimen should be used programmatically, not as operational research. The push, we have the data. We know this regimen is better. There is no reason that we should be doing more research and delaying access to this regimen for patients who need it today, not 1 year down the line, not 2 years down the line. Patients need it today. Patients are falling ill with tuberculosis today in every country in the world, including India.
Oh, yes.
Everywhere, patients are falling ill with drug-resistant tuberculosis, and we think that these patients should not have to wait to get these better treatment regimens. And WHO's guideline update also goes in the same direction, that these regimens should be made accessible by all countries sooner rather than later.
So now we come to access issues, which are a big obstacle and hindrance in actually transforming scientific gains into public health outcomes. So have any countries as of now started regulatory processes or to have this regimen, or is it?
Um, I am not the expert on the regulatory process, I'll have to admit, but I'm aware that many countries have started the process of
Okay.
registration of Ritomanit.
Huh.
Some countries, I believe, have succeeded or have completed the process of registration, and some countries have also included it in their new guidelines. So many countries, after the WHO guideline update, countries go through the process of updating their own national guidelines, and some countries have already gone through that process and updated their national guideline. There are different stages of approval, and we expect that sometime in this year, most of the countries would be ready with a new guideline, which would recommend this new treatment to be made available to all patients who have rifampicin-resistant tuberculosis. Accessing these drugs would probably mean that countries would have to get these drugs. Many countries, the middle and low income countries, might have to get these drugs from global drug facility through global fund funding. But there might be some countries which might be procuring it from their own national funds. But yeah, the global fund funding for the next funding period would also include funding countries for making these regimens available to patients suffering from rifampicin resistant tuberculosis.
Anything else you would like to add, Dr. Sinha, and also by way of a message for the World TB Day this year?
India has, as you said in the beginning, right? India has set ambitious targets. Ambitious targets should always be applauded, right? We should think that yeah, the country has done a lot in setting itself high targets. What we need to do now is to match our actions so that these targets are reachable, or we at least make progress towards those targets, significant progress towards those targets. I think that these short regimens will help not just India but all countries globally in achieving the SDG targets as well as the elimination targets that different countries have set. The shorter regimen will definitely help it because one, you will be spending your resources more wisely. You'll be spending less on treating each individual patient, which means that you can treat more patients or use that money to improve your diagnostics, diagnostic coverage, roll out CB-NATs in different parts of the country. And then secondly, you have patients who are in a shorter duration of treatment, meaning that healthcare providers then have more time to follow up more patients. So we are very optimistic. However, the optimism has to be matched with work on the ground. There is a lot of work to be done, and none of us can just sit down and just wait for things to happen. We have to take it forward together so that we can achieve these targets.
Very rightly said. And thank you, Dr. Sinha, for finding time to speak with us and enlightening our listeners on what is upfront and what is needed. And charity needs to begin at home and not from outside. And friends, we were listening to Dr. Animesh Sinha, who's advisor for TB at MSF UK office. Thank you very much.
Thank you.